Good morning, everybody. Over the next few minutes, I'll be speaking to you on patient selection for peripheral intervention. Now, when you think of intervention, normally mandates a pre-interventional assessment. Now, pre-interventional assessment can be categorized as a general and a cardiac risk assessment and a lesion-specific assessment. Now, general assessment includes surgery-related factors, grouping of surgeries as high, moderate, or low risk, and patient-related factors with the comorbidities the patients come with. So this is from the American College of Cardiology. As you can see, the peripheral vascular surgery, the aortic surgery, and indeed the carotid endarterectomy fall in the high-risk group. So we know peripheral vascular disease surgery is highly morbid and carries a high risk. Going on from there, what are the patient-related factors which matters? The high-risk subsets includes MI within 6 months, a decompensated CHF, severe unstable angina, arrhythmias, and severe valvular disease. Intermediate risk is post-MI, compensated CHF, chronic stable angina, diabetes mellitus, and creatinine of more than 1.5. Now, based on the different variables, multiple variables initially started by Goldman in 77, followed by Detsky, and then what we follow is the revised cardiac index, which was formulated in 1999 and which widely applied world over. Now, this has 6 variables. The 6 variables include high-risk surgery, ischemic heart disease, congestive cardiac failure, cerebrovascular disease, preoperative treatment with insulin, and a renal failure as denoted by a creat of more than 2. Now, each of these variables is scored a point. Based on this, no risk factors contributes 0.4% post-operative cardiac complication rate. One risk factor, 0.9. It increases exponentially with 2. It goes up to 7, and once you have 3, it's very high risk, 11%. Now, how do we going about risk stratification and proposing a probable treatment algorithm? If the patient has had a coronary revascularization in the prior 5 years, and the patient has no symptoms, it's safe to go ahead, be it endovascular, be it surgery. Now comes where if a patient has an indication which determines that patient has, even in spite or irrespective of his peripheral vascular disease, you need to address this issue. Does he need a revascularization procedure? If the answer is yes, he goes on straight for that. And the surgery, peripheral vascular surgery, indeed has to be deferred or postponed. Now, if it doesn't fall into this category, it's tricky. Then you go by the clinical variables as proposed by Lee et al. So if there's more than 3, either you have 2 options, either treat him conservatively or you offer him a less invasive modality. Like if the patient, the lesion morphology per se falls into a task D, but you assess the patient, you think it's highly risky, then you might give him an option, an endovascular option. Brief overview over the next few slides. I'll try and take you through aortoiliac, femoral, inflow and outflow, infrapopliteal and renal occlusive disease. So this is the classification we all allude to. Fontaine and Rutherford peripheral vascular disease. Majority of peripheral vascular patients who come in for intervention fall into 2A to 4 category with stages of Fontaine and 2 to 6 of Rutherford category. Now, if patient has confirmed PAD and the global risk you see, and if you find that there's no functional disability, so always all these guidelines help, but finally your decisions are tailor-made on the patient. So if there's no functional disability, there's no treatment to be offered, be it intervention or a surgical. All he needs is probably an annual monitoring for ischemia, be it the limb, the cerebrovascular or coronary status. Now, if a patient has disabling symptoms, you put him on a supervised graded exercise therapy, you maximize his medications with phosphodiesterase 3 inhibitors, statins, antiplatelets, you give him a trial of 3 months if there is no evidence of critical limb ischemia, and you reassess him. If there is persistent disability, then you have to choose based on the lesion morphology whether to go endovascular or surgical. Now, iliac disease, this is a tentative format which I will follow over the next few slides, where the lesion morphology per se, we can say is for a different endovascular procedure. There are gray zones where endovascular versus surgery may be considered, and definite lesion morphology suggesting a surgical approach may be better. So what are the lesions which do better with endovascular approach? Definitely a task type A. Task means, as alluded by Dr. Rahul Seth, it's a transatlantic inter-society consensus group delineation of the lesion morphology. Type A lesions are single stenotic lesions less than 3 centimeters, either in the common or external iliac, unilateral or bilateral. Type B lesions are again single stenosis not exceeding 10 centimeters and not extending into the CFA. Total of 2 stenosis less than 5 centimeters long, or a unilateral common iliac occlusion falls into the type B, where the general recommendation is to follow the endovascular approach. Now, type C lesions are more diffuse, as you could see. They're bilateral in exceeding 5 to 10 centimeters, involvement of the common iliac, unilateral external iliac occlusion, extending into the common femoral segment, or a bilateral common iliac occlusions. These are all type C task and does fairly well with surgery, but as more and more technology is refined and more patients are aging with more comorbid conditions, endovascular treatment is also an attractive option for these category of patients. Now coming to type D, these are diffuse lesions, more than 10 centimeters starting from the iliac, coming down to the common femoral segment. Unilateral occlusions involving the common iliac and the external iliac. Bilateral occlusions of the external iliac, and diffuse narrowing extending from the terminal aorta into both the common iliac and the external iliac segments. These do well with surgery, provided the surgical risk is not so much. Coming to femoropopliteal, we'll go through the same formatting as trying to address lesions as they're based on the task types. Definitive indications, gray zones, and definitive procedures, definitive surgical procedures. Now, type A lesions are less than 3 centimeters stenosis of either the SFA or the popliteal artery. Type B lesions are single stenosis, 3 to 10 centimeters, not involving the distal popliteal or the popliteal trifurcation. Calcified lesions up to 3 centimeters in length. Multiple lesions each less than 3 centimeters, stenosis or occlusions. And femoropopliteal type C or D lesions are best treated by a surgical approach. Single stenosis or occlusion longer than 5 centimeters. Longer lesions, occlusions, more heavy calcification, complete occlusions of the CFA, SFA, and trifurcation lesions or occlusions. These are best treated by a surgical regimen. Renal interventions is becoming more and more common, more and more prevalent, because most of us perform a routine renal diagnostic angiogram, flush angiogram, when we are doing a coronary angiogram. Now, we need clinical clues to suggest if our intervention is warranted or not. So, in common indications, the clinical setting encountered are one is accelerated hypertension, resistant hypertension, malignant hypertension, new onset azotemia, along with on treatment with ACE or ARB therapy, a discrepancy of more than 1.5 centimeters in the kidney size, sudden unexplained pulmonary edema or unexplained renal failure. Now, the definite class, what do you term by a hemodynamically significant renal artery stenosis? It is described as a 50 to 70% diameter stenosis with a 20 millimeter gradient, peak gradient pullback, either with a 5 French catheter or a pressure wire system, or a 10 millimeter difference in the main gradient, and or a visual estimate of more than 70% or by IVUS. Now, what are the class 1 indications for intervention in renal artery stenosis? There's only one. Hemodynamically significant RAS, recurrent unexplained congestive cardiac failure, sudden unexplained pulmonary edema. What are the class 2 indications where we know the treatment is beneficial? Hemodynamically significant RAS with resistant malignant accelerated hypertension, unilateral small kidney, progressive kidney size with bilateral RAS, solitary functioning kidney, or hemodynamically significant RAS with unstable angina. So, class 2B, where you're not very sure your treatment is going to benefit the patient, asymptomatic hemodynamically significant RAS, chronic renal insufficiency with unilateral RAS. Also, what are the class 1 transcatheter intervention status? options. One is renal PTA with osteoatherosclerotic lesions, PTA in a patient with FMD with provisional stenting strategy. These are class 1 indications. A word briefly about primary stenting versus the angioplasty approach. Stenting is superior. Stenting is superior in terms of procedural success and less restenosis rates. And last but not least, and a few indications for surgical indications for RAS. One is FMD with a complex anatomy. Second is atherosclerotic etiology with early primary branching where involves a bifurcation or trifurcation, multiple small branches, and atherosclerotic RAS along with a reconstructive aortic surgery. Thank you.